So thank you very much for the invitation to contribute. It's my first contribution to the Pharma Connect conferences. So I hope you'll invite me back for updates. So yes, as Professor Katerere said, I am going to be talking about epidemiology of COVID-19 in Africa, and we very much believe in leaving no one behind. For those of us who grew up during the HIV epidemic era, before it became endemic in Africa, we grew up with this phrase, know your epidemic to know your response. But what does that mean? And what that means is actually you need to understand the epidemiology of your epidemic in order to make evidence-based decisions. So I'm going just to start by reminding us of what epidemiology actually is. It is the study and analysis of the distribution, patterns, and determinants of health and disease conditions in defined populations. It underlies public health, shapes policy decision, informs interventions, and identifies targets for preventative health care. So here are just a couple of examples of what epidemiology looks like in action. So here on the left, we have the most basic information that you get from epidemiology, which is the number of cases. And this is the number of cases per week across the regions of the world. And you can see that actually Africa has the smallest epidemic. Two pertinent subject areas for our colleagues in South Africa. How do you decide who gets a vaccine, and how do you choose which vaccination formulation to use? So all these kinds of decisions are made based on the epidemiological understanding of your epidemic. So what do you actually need to know about your country and your neighboring countries' epidemic at the moment to make informed decisions? Well, you need to know the following. First of all, infection levels and transmission patterns, and also where people are being infected. And to do that, you need diagnostics. You need to know what variants or what types of viruses the people are getting infected with. So hence the variants. And to do this, you need your sequencing information. You need to know how to avoid infection. And the way you do this is you understand the transmission patterns and the transmission dynamics. And once you know those, you want to cut that chain of transmission through avoidance. And you do that using your local infection prevention and control strategies. These are your mitigation strategies. You want to know what the symptoms are. And this is important because human populations are heterogeneous. And just because one population's symptoms are defined as a particular set, it doesn't mean those are applicable to your local population. So you need to know how the disease manifests itself in your local population. You also need to know who is getting infected, and of those infected, who is getting ill, and of those that are ill, who is dying. This is where we identify local risk factors, and these vary because of the different population structures, population comorbidities, and also co-infections. So we know, for example, HIV is a major player in the etiology and also the outcome of COVID infection. You also need to know how to treat the infected people. These are your clinical interventions. And it's no good knowing how to treat the infection using equipment or resources that you don't have in your local setting. You need to know how to adapt your locally available resources for the clinical interventions. And this is the same thing with the last one, which is the response to therapy. Different populations have heterogeneous responses to therapy. So you need to know what works in your population. And this is a nod to precision medicine. So all this information is critical in epidemiology. And these themes will keep coming back. I will refer to them as we go through this presentation, and just to highlight how important they are. So let's look at the COVID-19 context-specific interventions in Africa. Interventions need to be evidence-based. So what have we seen in Africa, and what can we learn from one African country to the next? An example of Rwanda using robots to fight COVID-19. So this is robots in diagnostics. Local responses in Ethiopia and Ghana, for example. So Ethiopia has cut rent in some areas to alleviate the economic burdens. Ghana have provided free water and electricity for several months. The free water is really essential for hand hygiene, and the electricity alleviates economic burdens. We've seen the response by the trucking industry to get truck drivers tracked electronically, particularly to track infections, since a lot of these work cross-border. But we've also drawn on some of Africa's cultural practices in order to mitigate COVID-19 in communities. So here's an example from Ethiopia, where they have used the Ubuntu approach to shield vulnerable people as a mitigation strategy. And this is very interesting because this approach actually has been welcomed in Africa and has been impactful in Africa, whereas in Europe, it has been one of those that has caused a lot of discussion and have ended up not being implemented at a policy level in a lot of countries. So we need strategies for understanding the regional COVID-19 epidemiology. And I'm just going to give you an example of what we have been doing in this respect for our own work. We refer to TIBA. TIBA stands for Tackling Infections to Benefit Africa. It is an Africa-led, wide-ranging, multidisciplinary research program that explores and draws lessons from the ways that different African health systems tackle infectious diseases. We have partners in 9 African countries, and we have a leadership with a director, Professor Mark Woolhouse at the University of Edinburgh, myself and my colleague, Professor Moses Chimbari at UKZN as his deputy co-directors. And the 3 of us work together with our colleagues in the 9 African countries who are shown here. So each of the 9 TIBA African countries has a country PI, and that's their photograph here. And each of these PIs has a team of very able, very enthusiastic African colleagues who work with them to deliver on TIBA's aims. We also work with centers of excellence in the University of Edinburgh, as well as with pharma, in order to derive the evidence which can then be used into policy and practice to mitigate epidemic and emerging infectious diseases. Once we've got that evidence, we need delivery partners who then formulate and implement the policy and the practical aspects of intervention. And the stakeholders we work with include the African Academy of Sciences, the African Union, the African Union's technical wing, NEPAD, AUDA NEPAD, as well as WHO AFRO. In TIBA, we have a work package 6, which is the emergency response work package, whose aim is to enhance local capacity to respond to health emergencies. And I'd like you to pay special attention to these 4 ways we are doing this, because these 4 ways map directly onto that list that I mentioned earlier of what you need to know about your epidemic. So in TIBA, we are supporting the development of context-relevant diagnostics. We are supporting resource and data sharing. So this is open resource and open data sharing. We're capacitating real-time genomic sequencing and analysis, and we're maintaining resilience in the health system. So I'd like to give you working examples of these. So in terms of capacitating real-time genomic sequencing and analysis, pre-COVID, we had already trained partners from the 9 TIBA countries on real-time viral genomic sequencing. And this is done through the MinION system, which means it is portable and it is basically a lab in a box. It can be deployed anywhere in a rural setting, and you'll be able to collect your sequences in real time. And we have been really pleased that due to the networking abilities and the trusted partnerships we've been working in, several TIBA partner countries have used this TIBA resource in order to sequence their SARS-CoV-2 viruses at the moment. So these include TIBA Botswana, TIBA Kenya, TIBA Rwanda, and TIBA Ghana. And in terms of TIBA Ghana, actually, here's an example of the output of that genomic sequencing. This paper came out about a month ago, and Gordon Awandare, the senior author here, is the TIBA Ghana PI. And what we really like about this is not only is it showing the capacitation of real-time genomic sequences, aim 2, but they have gone further and freely shared this sequence information on GenBank. As they say here, this is an extract from their paper, and that is playing to our open resource and data sharing aim 2. The other things we are doing mostly in TIBA Edinburgh is data-driven research, and this is really the important meat, as it were, for today's discussions. What we're doing in Edinburgh is using open data sources to look at the epidemiology of Africa's epidemic. We're looking at the genome sequencing for the African viral genomes. We're looking at the mitigation strategies that were put in place by different countries, and we're looking at how the populations adhered to those and their impact not only on COVID transmission, COVID epidemiology dynamics, but also on the wider aspects of human livelihood. We're also looking at the different countries' testing capacities. I'm sure a lot of you will recall the news item saying, well, Africa's epidemic is low because the testing capacity is low. This is not necessarily the case, and we have shown some data to this effect. And we're also looking at the COVID-19 global health governance. So who decides what? Who pays for what? And I think my colleague, Professor Katerere, did mention this important aspect of who's doing what exactly across the continent for the regional response. So the output of all this work, which is updated regularly, is available on our web page here. So getting back to what we've actually found with the analysis from here. I obviously don't have time to show you the output of all these 5 data-driven topics, but I'm just going to focus on the first one, the epidemiology. So what we have here is a movie. We have been collecting data that is produced by WHO AFROM from member countries. And what this map shows is the rate of change in the numbers of COVID-19 cases across Africa. And what we have here is that yellow and red means it's increasing, green means it's decreasing. In the corner here, we have the summary across the continent. And as you can see, here's a timed representation of that, which I'm going to speed up a little bit in the interest of time. You can see Africa's epidemic being mapped, and here's the first peak that occurred around August. But if you look at the map, you can see there's a lot of heterogeneities. Colors are changing throughout the time. So what's happening within country does not necessarily tell you what is happening across the continent. And what is happening across the continent is very important, because if the epidemic across the continent is on the rise, then your country needs to be prepared for infections being seeded from other countries, as well as infections within that country following that curve rising. So we can see here the peak of the second wave of Africa's epidemic, and really nice news that it's going down. So this is run up until the 8th of February, so Monday this week. So this kind of information is what we are generating here in Edinburgh on the Africa data. And we're doing it for all those topics that I mentioned earlier. And it gives us a picture of what you can do with the information from epidemiology. So moving forward, what we want are evidence-based local and regional responses. Local responses are easy. Here are 2 recent examples from this month. Kenya reopening its schools, and South Africa lifting the alcohol ban. Now, these are supposed to be based on analysis of the epidemiology data in the countries, because that's the evidence base that allows you to know whether it is now a little bit safer to open schools or a little bit safer to lift the ban. But what happens in your neighbor's country or in other regions of Africa matters to what's happening in your own country. And here is an example that most people will relate to, how remittances are being affected by COVID-19. So to look at the entire package, SADC has been discussing the regional response to the pandemic. And here's a blueprint. I think this particular one was published much earlier on in the pandemic. And this one focuses on health, transport, and food security sectors. Now, in order to build that response and make sure it is sustainable, it is robust, and it is deployable when it's needed, you need to strengthen that. You need to strengthen the regional response. And how do you do that? So I have put together some regional assets which really would ensure that Africa, particularly the SADC region, can respond not only to this current pandemic, but certainly to the next one, of which there will be. So we need to be prepared. So how do we do that? Well, we need to ensure we have early warning systems. So this is surveillance at regional level. We also need a networked task force for rapid deployment. So this includes people like the chief medical officers and the chief scientific officers. I noticed my colleague, Professor Katerere, also mentioned the requirement of this networked personnel task force. We need open data sharing so that we can understand what is going on in one country and prepare for any consequences in other countries. And this is helped by the next asset, which is effective communication and information dissemination. And finally, we need a networked and well-resourced series of reference labs. Now, this looks like an idealistic list, which every scientist would jump up and down and say, this is fantastic, let's do that. But how realistic is this? Well, I'm delighted to say that we have an example of where this has already been thought of, and this is in the Horn of Africa, where much earlier on in the epidemic, they were making plans of how that region can respond as a region and not as individual countries to the COVID-19 pandemic. And you see that quite a lot of the tools or assets they've put here are also mapping onto the ones that I have listed here. They went further to cost this, and you can see in orange the costings of what they thought each of these systems would be. So, for example, the national laboratory system, they wanted just under $900,000 US. So the question then becomes, who is going to pay for this? And this was a call for funding, but I think in Africa we can do better. And I think the way to do that is through this, the Abuja Declaration. African governments in 2001 made the Abuja Declaration, which was to allocate at least 15% of their GDP to their health sector. This was meant to strengthen Africa's health systems and ensure disease preparedness for outbreaks. And this would have been an ideal pot of money that could be used to maintain those regional assets. And I'm hoping that COVID-19 has made governments realize the need to accelerate the realization of this declaration. So I'm going to end there with the science and just thank the teams here in Edinburgh that have been involved in some of the work that I've shown here, both the science team and the support team. And I'd also like to thank the funders. We are funded by the UK government through the NIHR unit to the tune of about £8 million. 80% of that being spent in Africa. And I'd also like to just thank a lot of colleagues in TIBA. I've particularly picked this group because these are evidence synthesis group. So we ran some training in TIBA throughout to teach scientists how to synthesize evidence for policy. And we also involved policymakers. So you can see our colleagues from the African Union and Alda Nepad here. I'm going to stop there. Thank all my colleagues and thank you for your attention. And if you'd like any more information on what we are doing, please do look at our webpage here. Thank you very much.
Thank you very much, Francisca, for that. Well, inspiring in the sense that there are things that are happening. So tell me something, in terms of choosing partners, how do you get to find partners to work with?
So usually the partners that come to you are usually the keenest and easiest ones than the ones you go and look for. So what happened in the formation of TIBA, initially, we wanted to pick very strong partners in Africa and partners interested in infectious diseases and particularly also neglected tropical diseases. We looked for partners and they came to us and asked to join TIBA. We are now just getting ready to put in TIBA 2. And what we have done is decided, okay, we'll keep the strongest African partners that we have, but it's no good concentrating the funding and the resources in those partnerships that are already well established. Let's also ensure we have what we call, excuse this if it sounds sexist, little sisters. And so each of our very strong African partners will now be asked to pair up with a very weak partner in a country that is not normally funded. So for example, our Sudan, TIBA Sudan will be partnering with South Sudan. We've also got Sierra Leone coming on board, because it is really, really important that we strengthen as many African institutions as possible to support their governments and also support the regional response.
Okay, thank you. Are there questions from the colleagues here, maybe? Otherwise, we can take questions later. No questions. Okay, please feel free to make comments or questions in the chat box, and then we can come back to them.